Let's join Dr. David Weissmiller for a discussion on Maternity Care 1.
I do not have anything to disclose. Here are the learning objectives that we have set forward. You know what that is? It's a cabbage patch. That's where babies come from. That's me. No, it's not. Which one of the following tests is recommended in routine prenatal care? Serologic testing for herpes simplex virus, pap cytology in each pregnancy, cystic fibrosis carrier screening before conception, or screening for asymptomatic bacteriuria by urine culture. Okay, and the majority of you chose D, screening for asymptomatic bacteriuria by urine culture, and that is the correct answer. As we look at the initial prenatal visit labs, now initial, typically we'd like to do these at about 9 weeks. Sometimes we do them at 38 weeks, depending on when the patient initially presents for obstetrical care. Blood group and RH, antibody screen looking for isoimmunization. We screen for anemia, although as you will see, there is insufficient evidence that makes any difference. Rubella antibody titer. The recommendation is if you're at high risk, a syphilis screen 3 times during the pregnancy. Everybody gets screened for hepatitis B virus via surface antigen. Cytology as needed. If you had your pap a year ago, you need one every 3 years, then you don't need one today. Pregnancy does not change that. Also, under 21 in pregnancy does not change that. Okay? STI, both GC and chlamydia. Urine culture, although recommended between 11 and 16 weeks, I will tell you in practice, we get it whenever they present. We don't wait until 11 weeks if they come in at 9. Sickle cell screen, HIV screening, varicella screening, cystic fibrosis screening we'll talk about, and then gestational diabetes. Keeping in mind that there is a discordancy in the literature and recommendations in terms of, do we screen high-risk women at intake for pre-existing diabetes versus screening everybody routinely at 24 to 28 weeks. Here's the issue with anemia. This was the ACOG practice bulletin from 2008. We know that iron supplementation decreases the prevalence of anemia at delivery. Why do we worry about it? Because it is not a benign issue. It's associated with low birth weight, which is an estimated fetal weight of less than 2,500 grams, keeping in mind that low birth weight infants are at increased risk for most chronic diseases as they age. Preterm delivery and perinatal mortality. Level C recommendation, that is, if you have iron deficiency anemia as defined by less than 11, 10.5, or 10 milligrams per deciliter in your hemoglobin in the first, second, and third trimester respectively, then you would treat with supplemental iron in addition to the 20 to 40 that they're getting in the prenatal vitamin. Here's the most recent recommendation from the USPSTF. Current evidence is insufficient in terms of screening. Current evidence is also insufficient to assess the balance of benefits and harms in terms of routine supplementation. In terms of sexually transmitted infections, Hep B, HIV, syphilis, chlamydia and gonorrhea, the USPSTF says if you meet the high-risk criteria, the CDC does recommend screening for chlamydia and pregnancy universally. They do not recommend, in terms of the USPSTF, screening for chlamydia if you're pregnant and not at increased risk. And in terms of gonorrhea, it's an I recommendation. Asymptomatic bacteriuria, very important to understand the definition. It's greater than 100,000 CFU per mil of a pathogenic species. If you see lactobacillus or staph, with the exception of saprophyticus on the latter, that's a contaminant. The most common thing you're going to see is E. coli. Why do we worry about it? Well, there are higher preterm delivery rates in women who have asymptomatic bacteriuria. Pregnancy itself does not increase the risk of asymptomatic bacteriuria. Culture at the first prenatal visit. If it's negative, we do not rescreen again for asymptomatic bacteriuria. It's almost unheard of. So if on the examination they give you a woman who's coming in for a routine prenatal visit, she's dipping LE positive on her dipstick but has no symptoms, and her urine culture was negative at the beginning of the pregnancy, you do not repeat the urine culture. One exception for rescreening is those who have sickle cell trait, and the current recommendation from the AAP and the ACOG is to screen once a trimester. They have increased risk for asymptomatic bacteriuria. Now, which of the following antibiotics should be used in the empiric treatment? You know, somebody spit on the plate and you got to treat empirically. You don't have the sensitivities. Would it be AMP, clindamycin, cephalexin, or ciprofloxacin? Okay, let's see what we came up with here. Excellent. The correct answer is cephalexin. There are very high rates of resistance to ampicillin. It's not recommended. We also recommend a 7-day course, not a single dose. They have not been widely studied. It's important to do a urine culture after therapy. If they haven't cleared, do they have persistent or recurrent? These patients may benefit from suppressive therapy. Now, what are the antibiotics that are considered safe and what ones do we typically avoid? I put an asterisk by nitrofurantoin and sulfonamides because during the second and third trimesters, they may be used as first-line agents for infection. They can be used in the first trimester if there's no other agent that is appropriate. So it's just the static in the literature about those two antibiotics still. This is why we treat it. You can see the number needed to treat is 20. I need to treat 20 women with asymptomatic bacteriuria to prevent one preterm delivery. Very important because the incidence of preterm delivery in the United States continues to rise. It is not yet completely stabilized. Herpes. This should be screened for by history. The concern is if you have primary HSV and haven't seroconverted, of course, the unborn child is at risk. If it's acquired during pregnancy, of course, these women are going to have potentially the need for additional treatment, and particularly as we reach labor. Now, if we look at suppressive therapy, I've got a history of herpes. I had an outbreak during the pregnancy. These women should be offered suppressive viral therapy at or beyond 36 weeks of gestation. Why? You can see that the rate of C-sections for recurrent herpes is decreased by 40%. Remember, vertical transmission in somebody who is completely seroconverted, even if they had an outbreak, is somewhere between 0 and 3%. We do C-sections in those who have a prodrome or an outbreak to make sure that that goes as close to 0 as possible. Well, this is another way that you can get that down because of suppressive therapy. Daily suppressive therapy can be acyclovir or valacyclovir. HIV, it should be offered as a routine opt-out test. I don't want to have the test done, as opposed to, do you want to have the test done, okay? So routine opt-out. It should be done twice during the pregnancy. If it's not done, you can offer it in labor. Any positive test in labor, you would initiate therapy. We always get consent for any test that we do. Evidence of immunity to varicella. The recommendation is to screen through history. I know that many places are now screening serologically. However, the stated recommendation is through history. Cystic fibrosis, information should be available to all couples now, regardless of their race or ethnicity. If they are at increased risk, it should be offered before conception. Caucasian, European, or Ashkenazi Jew in particular may elect to either do it sequentially or concurrently. Sequentially, I test both at the same time. Concurrently, I test mom or dad and then the other. No routine screening. Hepatitis C, of course, HPV. One word on parvovirus B19. This, you will recall, is embryotoxic, not teratogenic. The concern is infection during the first trimester. Issues will peak during that second trimester. If mom has completely seroconverted, the risk to the baby is practically 0. If she has not, because this is the first time she's been exposed, then fetal monitoring is not uncommon because you've got to be worried about high drops and fetal anemia. Per ACOG 2013, at 24 weeks gestation, you perform a 1-hour glucola test, which is elevated at 166. You would next repeat the 1-hour glucola in 1 week. Have the patient see the dietitian for diabetic diet information. Order a 3-hour glucose tolerance test, or start low-dose metformin. Okay, the correct answer is C. Order a 3-hour glucose tolerance test. We've done a screening test. Now we're going to do a diagnostic test. We worry about this because we are seeing an increase in this condition in the population. Factors that contribute are maternal obesity and older age. We worry about it because these women are at increased risk for other complications during pregnancy, particularly hypertensive disorders. They're at increased risk for cesarean and an increased risk of themselves developing diabetes later in life. Now, there are a host of recommendations out there in terms of how one should screen. I'm going to focus on the USPSTF. They say to screen asymptomatic women after 24 weeks for carbohydrate intolerance first diagnosed during pregnancy. That's gestational diabetes. They believe that the current evidence is insufficient to assess the benefits and harms of screening prior to 24 weeks, i.e., looking for undiagnosed pre-existing type 2 diabetes. Both ACOG and the ADA think it is reasonable to screen women. Now, if you were going to screen women, how would you do it? Well, you can use it in any way. An A1C, that should be greater than or equal to 6.5%. A fasting plasma glucose, greater than or equal to 126. One-step, two-step method. A random plasma glucose greater than 200 on 2 separate occasions. Any of those can be used. The ADA would say, okay, maybe we should screen people at high risk for pre-existing diabetes. Well, how are we going to know who's high risk? They're bigger. They've had a large gestational age infant, they've got glycosuria, they have PCOS, strong family history, ethnic background, which is essentially everything but Caucasian. If they would screen negative, you would repeat it at 24 to 28 weeks. Now, ACOG is a bit narrower in terms of looking for pre-existing diabetes. And they would say if there's a prior history or a known impaired glucose metabolism or obesity, then you would screen them at that first prenatal visit. The USPSTF says there's insufficient data that says that makes any difference. The 2-step approach is what we typically use. 135 or 140 is the cutoff. You then go to the 3-hour diagnostic test. If your 1-hour screening test is greater than 190, you don't even need to do the diagnostic test. 90% of them are going to have an abnormality. We do an overnight fast for the diagnostic test. They get a fasting plasma glucose. They then get 100 grams of oral glucose polymer. We check a blood sugar at 1 hour, 2 hours, and 3 hours. Of those 4 values, if 2 of the 4 are abnormal, they're diagnosed with gestational diabetes. The screening process can be used either at 24 to 28 weeks, which is routine, or you can use the same screening process at the beginning of pregnancy if you're going to screen those who are at high risk. Later in pregnancy, a couple words on open neural tube defects using a maternal serum alpha-fetoprotein, aneuploidy, combining that one serum analyte with 3 others to look for trisomies in particular, screening sonography, anemia, and then highlight group B strep. It will be on the exam. I promise you there'll be a question on group B strep. Okay, MSAFP and the quad screen. So if you have a high MSAFP, I want to be screened for neural tube defects. Great. We're going to do a maternal serum alpha-fetoprotein on you. If it's high, and it's a calculated risk, you're at increased risk for an open neural tube defect. Now, you can combine that one analyte with HCG, estriol, and dimeric inhibin A to look particularly for 2 trisomies, 21 and 18. This is a calculated risk, the most common reason for an incorrect value or a false positive, because it's calculated based on a number of factors, including gestational age. You told them the wrong gestational age. You know, the patient says, oh yeah, I'm 16 weeks along, and you finally evaluate and she was only 8 weeks when you sent it. Okay, that's the most common reason. There are many ways to detect trisomies. I'm highlighting the quadruple because that is the most universally accepted right now. According to the CDC, all women of childbearing age should consume how much folic acid on a daily basis? 4 milligrams, 0.4 milligrams, 1 milligram, or 0.8 milligrams? How much folic acid? Okay, how do we do on this? Fantastic, good. So we just squeezed through there. 50% said 0.4 milligrams is what the CDC recommends, and they have recommended this since 1992. Periconceptional use of synthetic folate. A diet rich in naturally occurring folic acid has not been shown to do the same thing, has reduced the risk of neural tube defects by up to 80% in the United States. If there's a history of neural tube defect, you should be on 4 milligrams per day, preferably 3 months before conception. The Institute of Medicine does make a different recommendation. I would know the CDC recommendation. One caveat in terms of folic acid with epilepsy. We know that in women who have epilepsy, there is a inherently low serum folate level, and it's independently associated with an increased risk of major fetal malformations. We don't know if supplementing more is able to override this. However, the recommendation is that if you're on valproate or carbamazepine, you be treated as if you had had a neural tube defect and you'd be on 4 milligrams per day. Any of the other anti-epileptic drugs, you get placed on 800 micrograms per day. According to ACOG, which of the following statements best characterizes the use of sonography in pregnancy? It has the ability to diagnose minor fetal anomalies. It is best carried out at 12 weeks estimated gestational age. It is an accurate method of determining placental location. Routine use is recommended. Okay, excellent. It's an accurate method of determining placental location. Of course, most people want it because they're trying to figure out what the sex of the baby is. Well, we have to know. I mean, this whole industry of reveal parties has developed. Sonographic assessment. Here's how we define screening ultrasound. We're assessing the pregnant abdomen between 16 and 20 weeks. Please highlight in the absence of a specific indication. And what are we trying to get from this? How many are in there? Where's the placental? If they're beyond 20 weeks, an assessment of amniotic fluid, a survey of fetal anatomy for gross malformations, and evaluation of the maternal pelvic masses. ACOG, the American College of Radiology, and the American Institute of Ultrasonographic Medication, all accurate method to determine gestational age. So that's very important because accurate gestational age means we prevent postdates, right? 2, you can find major fetal anomalies. Please highlight the last point. Specific indications are the best basis. 18-year-old G1P0 at 40 and 5/7 weeks presents stating that she thinks her water broke 18 hours ago. An exam confirms rupture of membranes. The patient is afebrile with a non-tender uterus. The fetal heart rate tracing is reassuring. She's not contracting. A GBS culture obtained 4 weeks ago was negative. The patient has no known drug allergies. In addition to induction of labor, which one of the following is the most appropriate management for this patient? A, no antibiotic prophylaxis for the fetus. B, ampicillin. C, clindamycin. D, vancomycin. Okay, excellent. Good, good, good. A is the correct answer. A is the correct answer. Okay, as we start this conversation on Group B strep, keep in mind universal screening has been recommended for some time now. There are 2 groups of women who do not get screened. One would be I had a previous infant affected with early onset GBS sepsis, or at any point during the pregnancy, somebody got a urine culture on me, doesn't matter whether I was symptomatic or asymptomatic, and I had any CFU per mil of GBS, i.e. I had GBS bacteria. Don't confuse that with asymptomatic bacteria and needing 100,000. 2 different things. We do a culture of the lower vagina if they don't meet one of those 2 non-screening groups. It's then inserted into the rectum because GBS is harbored in the sigmoid and rectum. We got to order susceptibility testing on isolates. This is going to be particularly important if they are pen allergic. Please highlight this. If your culture is negative within 5 weeks of delivery, you do not need antibiotics to prophylax the baby, even if risk factors develop. This is where people get confused. Don't confuse prophylaxing the baby with treating the mother. GBS prophylaxis has nothing to do with treating the mom. We're just using mom as a conduit to get something to the baby, okay? So, if you don't know the status and they're at less than 37 weeks, the baby gets prophylaxed. If you don't know the status and they've been ruptured for longer than 18 hours, the baby gets prophylaxed. But if you know those two, she's beyond 37 weeks, or she's negative and ruptured greater than 18 hours, the baby doesn't need prophylaxis. Where the tricky part comes in is, in our case, if mom does develop a fever, you're still not prophylaxing the baby. She's GBS negative. There you would choose to treat the mother, and you would not treat the mother with antibiotics. We typically prophylax the baby. Now, this is what they're going to ask you for. So you got to know this algorithm. They're going to tell you that mom is pen allergic. And then they're going to tell you the severity of her allergy. And you can see there, if she does not have a severe reaction to penicillin, i.e. anaphylaxis, angioedema, respiratory distress, or urticaria, then she gets cefazolin. If she's had a severe reaction, please highlight, in order to use Clinda, you have to have susceptibility to both Clinda and erythro. If you don't have susceptibility to both, or you don't know them, then you got to go to Vanc. So the question I would write would be, she's pen allergic, she had a severe reaction, it's sensitive to Clinda. What's the drug? Vanc, because you got to be sensitive to both to use Clinda. Okay. 26-year-old female presents with lower abdominal pain and vaginal bleeding. The last menstrual period was 7 weeks ago. Urine pregnancy test is positive and a quant beta HCG is 2500. Transvaginal sonography shows no evidence of an intrauterine gestational sac. The baseline laboratory tests, including a CBC, liver function, you name it, are all normal. She's treated with a single dose of IM methotrexate. 4 days later, she presents for reevaluation. The beta HCG has gone to 3,800. 7 days later, it's gone to 4,400. Which of the following is the most appropriate next step? Repeat the methotrexate. Repeat the transvaginal sonography to see if there's a viable intrauterine pregnancy. Do a laparoscopy with salpingostomy or expectant management. Okay, what did we come up with here? Let's see here. Okay, so we have a learning opportunity because the correct answer is C. C. Laparoscopy with salpingostomy. Okay, so what we're talking about here is ectopic. The most strongly associated risk factors, which is everything in pregnancy, it happened before. If they give you any question on the exam where they say, in a previous pregnancy, that's the key because it's going to happen again. Not always, but bet your life it is. Increased risk for ectopic also with history of genital infections or current smoking. Early diagnosis is very important here. Now, why did I give you those quantitative beta HCG numbers? Please highlight this. By a beta HCG quantitatively of 1,800 on a transvaginal scan, you should see an intrauterine gestational sac. By 3,500 on a transabdominal, you should see an intrauterine gestational sac. So the fact that you couldn't see something at 2,400, don't repeat the ultrasound. You got to assume I've got an ectopic pregnancy someplace because I should be able to see it. We're beyond 1,800. Now, if I had told you it was only 900, the correct answer would have been repeat the ultrasound if mom's hemodynamically is stable, et cetera, et cetera. These typically occur at about 7 weeks. Can be later, can be earlier, of course. Beta HCG not doubling is alone, you cannot differentiate between an ectopic and an IUP. Chorionic villi, in terms of a diagnostic curettage, if you don't get villi when you do your diagnostic curettage, you got to assume there could be an ectopic. Now, keep in mind, you would only do the curettage if the beta HCG levels are falling or when the levels are elevated and the ultrasound doesn't show an IUP, in general. How would we use that? I do a D&C, decreasing HCG, the villi are absent, I just follow the HCG titers down. No villi, I've got a rising or stable HCG and a mass, they're going to have to go to laparoscopy. No villi, rising or stable HCG and a small mass, medical treatment. Hemodynamically unstable patient, they're going to get a laparotomy. Early diagnosis in the patient stable, they'll get a laparoscopic salpingostomy. You can use medical management with methotrexate, single or multiple doses. The key here is you measure the beta HCG on days 4 and 7. If the difference in fall is greater than 15%, you just repeat it weekly. If the difference is less than 15%, you repeat the methotrexate dose and begin a new day. It's still falling, but it's less than 15%. Ours was rising. That's why the recommendation is to go for the salpingostomy. Single dose, easier to administer. Contraindications, you've got a larger ectopic greater than 4 centimeters. There's the summary for the diagnosis of ectopic. Please put that in your study folder. That will summarize what's important in terms of making that diagnosis. Expected management, they're stable, minimal pain, reliable follow-up. Small adnexal mass, beta HCG is less than 1,000 typically and falling. First trimester bleeding, in addition to ectopic, of course, you got to think about spontaneous pregnancy loss. Just 2 things to remember. 50% of these are the result of chromosomal abnormalities, and no bed rest, drug therapy is going to correct the etiology. The writing is already on the wall by the time you're starting to get the cramping and the bleeding. For which one of the following conditions is there good evidence for the routine administration of anti-D immune globulin to an unsensitized D-negative patient? If you get this question correctly, you might want to consider taking the maternity care module. Because here we're not just asking about where would you do it, but they want to know, is there good evidence for it? So it kind of ratchets things up just a notch. After first trimester pregnancy loss, abdominal trauma, second or third trimester antenatal bleeding, and attempting an external cephalic version, a little wrestling match with the baby from the outside. Okay, so the majority of you chose A after a first trimester pregnancy loss, and that is the correct answer. So here's the level A evidence for giving RhoGAM. Number 1, 28-week gestation, mom's Rh negative, and I don't know what dad's Rh status is. Mom's Rh negative at delivery. I deliver a positive infant, i.e. D positive, mom gets it. After a first trimester pregnancy loss, and then after any invasive procedure, chorionic villus sampling, amnio, any place where there could be a fetal maternal hemorrhage. Level C evidence is threatened abortion, second or third trimester antenatal bleeding, I'm doing an external cephalic version, or there's been abdominal trauma. That's it. Thank you very much for your attention.